Welcome back, everyone. It's still the House Healthcare Committee on Tuesday afternoon, the 14th, and we're continuing our conversation around suicide prevention. And we're going to continue with Chris Allen and look at 988. So go for it, Chris.
Yeah, so thank you. So this is 988. We'll actually go back. There's the slide that I wanted. So here's the history of 988. This is us building on the existing suicide prevention lifeline. So just to give a brief timeline of kind of how things operated over the past since 2018. So in November 2018, NCSS comes on as the first National Suicide Prevention Lifeline Center, and they're still with us answering 988 calls. Then fast forward to February of 2021, Vermont receives the 988 planning grant and builds the 988 planning coalition. So moved in between 2018 and 2021. Nationally, there was a movement to move it from the National Suicide Prevention Lifeline to move it from a 10-digit number to a 3-digit number. Now, come June 2021, NKHS, Northeast Kingdom Human Services, begins answering calls as Vermont's second Lifeline Center, and they're still with us as well. So, and then in July of last year, 988, July 16th to be exact, 988 dialing code was officially launched. So you can still dial the 10-digit number, but it will forward to the 3-digit.
Great.
And NCSS and NKHS are the two lifeline centers within Vermont. Both of them answer chats and texts. And then we contract with a backup center as well called Headrest, which is in New Hampshire. So they get any overflow.
Okay.
And just to add, actually, in October of last year is when NKHS and NCSS started answering more chats and texts. So it's a little bit newer as opposed to the calls. So looking at some numbers from October through January, we haven't received February's data right now, although we'll likely get it in the next few days. So one important measurement that I'd like to point out is the number of call volume that we've seen, how it's steadily increased over the past 4 months from October to January. So in October, we had 720 calls. In January, we had 958 calls. Now, if I could bring your attention down to the answer rate, which is the lowest column here. And you'll notice that our answer rate for calls has not fluctuated despite that increase in volume, which is a really big win for us in such a new program. So NCSS and NKHS are covering 24/7 calls within the state of Vermont. Just pointing out a few different metrics too regarding chats and texts. You'll notice that we don't receive as many chats and texts in Vermont. Not really exactly certain at this point about what to pinpoint that on anything, but just something to keep in mind because the percentages will really fluctuate in terms of answer rate from month to month. As you'll notice, in January, we had a 52% answer rate for chats as opposed to November. We had 13%. So, and we're not certain of, for chats and texts, those are typically geared towards youth and young adults reaching out, and they're able to answer a a pre-chat or text survey, which outlines where they're contacting the Lifeline Center from, what their age is, and it's an optional question of sharing their name as well. But just wanted to offer that as well.
I think we have a couple questions, Topper.
What does answered mean?
What does answered mean? So someone within the state of Vermont or at headrest, a call was answered. So there was a call from within the state of Vermont with an 802 area code that called 988. And
Be a call received?
so that would be a call received that someone,
So what's the difference between received and answered?
so answered would be someone at a Lifeline Center, so at NKHS or NCSS, actually answered that call from a Vermonter
And talk to someone.
and talked to someone.
So what's happening with the ones that aren't getting answered?
That goes over to headrest. So they're our backup center.
So the answered are being answered in Vermont.
Yeah,
So like in January, there's 83% that were answered in Vermont by a Vermonter, one of our DAs. And then the 17%, I think that's right math, would go to headrest.
yeah,
And they would get answered?
yeah. And if headrest for some reason wasn't able to answer it, it would roll up to the national queue. So there's a national network as well.
So every call gets answered by someone.
Every call gets answered by someone.
Sorry.
That's okay. And the last two columns in December and January. Chats with 3, and 60% of them were answered. Okay, and then the chats with 30 the next month, and 52% of those were answered. So, does that mean that less were answered because there aren't enough staff to do it, or I'm trying to figure out why they're.
It's a great question and good
27
observation.
more chats.
Yeah,
and
so
less people.
yeah, so right now we do not have chat and text coverage 24/7 within the state of Vermont. We're working on building that capacity to be implemented by July of this year.
Leslie?
So is there an algorithm once the call is received, like where does it go? How does the person get responded to?
So they would, if I hopefully I'm answering
You're not
your
very
question.
articulate. We have a lot of calls and chats, but what kind of referrals get done? What's the responses to the call?
Yeah, so that would be, it's a great question, and that would be dependent on what the individual is searching for that reaches out to 988. So some person might be in crisis. They're talking to a trained individual that has gone through extensive training to be adequately prepared to answer that call. And more often than not, we're decreasing what is called imminent risk of harm to themselves or to others.
Just by talking?
Just by talking.
Might they call 911?
They could call 911 as well.
So I'm just thinking of the sort of continuum of response.
Yeah,
Might be, conversation, but it might be calling 911.
it could be. Yeah. And then there's also community callers, right? If I'm concerned about the mailman, he hasn't showed up in the past couple of days or he looks a little down, I might reach out to 988, ask them to see if they have any resources that I could connect the mail person to. Something simple as that.
Thank you.
Are all calls that the center gets, are they all suicide related? Are they all, or do you get a number of these calls that are just off the wall calls? Do you have any way to know that? You may not have any way at all.
It's a great question. I don't know any way to know that
Sure, yeah.
specifically, but I would say that I haven't been made aware of a call that or of Lifeline centers reaching out to me. I have a weekly meeting with them,
Yeah.
of them reaching out to me saying like, hey, we're getting, like the latest TikTok rage is 30, you bombard the Lifeline center and we've gotten 30 calls from
It
miscellaneous.
just seems like 958 calls plus.
Well, I think it can be someone in crisis, someone, again, reaching out for resources.
Yeah,
Okay, so they're not imminently ready to commit suicide. They're looking to do something else.
They're looking to talk to someone. They could be in
Yeah.
crisis. They don't want to go to a ER. They want to talk to someone as.
So it may be different than really okay, I guess I got it.
Is it what is it technically called? A suicide and crisis hotline, or what's like the national?
suicide prevention lifeline.
Just suicide prevention. But I think in the literature that I've been seeing, it says and crisis.
Yeah,
Yes, right?
Yeah, to be clear, that it's not just for suicidality.
So he says it's, a lot of these are NCSS. Is this a center where they answer the call, or you got operators all over, or?
it's a center
It's a
at
center,
NCS.
okay.
Yeah, so they have
So
dedicated
there's on
staff.
staff duty there, it's not somebody answering at home and didn't refer them to somewhere else, okay?
Correct, yeah.
Great. I think we can keep going.
Yeah. So I know that there was questions about the revenue and expenses of 988. So this, we can spend as much time on this slide as we would like. I may not have all the answers, but let's go through it line by line. So in FY24, our revenue for current state funding is at 441.59. Now, below that, we're looking at federal grant revenue. So that's a little bit of money from mental health block grant. And then the rest of it is from SAMHSA, is 684,453. So right now we're looking at total revenue for FY24 as it currently stands is just over 1.1. Our current expenses, this is based off of call volume that we currently have. So it's more like a point in time in terms of the level of service. Our Lifeline centers in terms of operating will need 1.146.
And that's to operate 24/7
That's to operate 24/7.
at the volume we have today. Okay.
And that's also keeping in mind that we do not have chats and text at 24/7 capacity right now. But we do have it. We do have 24/7. We're covering 24/7 for calls. So in addition to the Lifeline Center's expenses, we have marketing and other one-time expenses of 187, 257. So really just making sure that people are aware of 988. And we also have a follow-up pilot that's also a part of that, that marketing and other one-time expenses. And that the total projected expenses for FY24 would be 1.33870. So right now, as it currently stands, we are seeing a gap between our expenses and what the revenue is right now of 209,258. So originally the budget request was for 275. Now with this updated information, especially regarding the call volume from January, because of that information, we're able to kind of zero in a little bit further on what that number is for FY24.
And so the number we put in our budget letter was, do you know by chance? I think it was 250.
Okay.
Maybe. Somewhere in this pile of stuff. Yeah, it was whatever was requested.
50 cents.
275.2 was in the budget letter. Okay, so it's close. But this is for 24.
Yeah,
So how long do we have that federal grant revenue for? What happens in 25?
we come 25, We do not have any federal money.
That's a deal.
So
Looked like you were in trouble.
I'd say we're all in trouble. We're in the same soup on that one. But yes, that is definitely a concern. So kind of breaking this out even further, if for the 440 plus the 209, and then this 497, 196, that is the ongoing additional base budget that we would need, that 497 and FY24 based on our current level of service. So what we're answering right now for calls, chats, and texts to cover the Lifeline centers if DMH is appropriated the 209 in the FY24 budget.
So you need 497 more.
In 25.
Correct.
Why wouldn't you need the whole grant amount?
There you go.
So that's a good question. And I don't know the full, I would defer this to Shannon Thompson,
Okay,
who is
that's fine.
our financial director on that, as she's more versed in the budget of this and the funding streams.
I think for the committee, we just have to kind of put a placeholder here when we do budget next year to dig into this. Okay. And this is today, we're probably gonna have increased numbers and we're gonna get to the 24/7 chat. So you can get to the 24/7 chat and text in July with the funding you have, or only if the additional budget money goes through.
Only if the additional budget
Goes
goes
through.
through. Yeah, so the 209.
Okay,
Yeah, that is really, because right now we're covering just about 100 hours of chat and text. And so we have some ground to make up. And I should also add is that NCSS and NKHS, we don't currently service 100 unique hours. So there's some overlap between the two centers in terms of chats and texts that are going to both centers, if that makes sense. Yes.
Just a quick question regarding your federal grant funding. That grant amount right there is from a FY23 grant?
The 684. Yes.
So I know the president's budget actually has a lot of money in it right now for 988. Did you see it came out just the end of last week, I think.
I have not, no.
I think that's promising. I mean, I'll be taking a deeper dive. I just did a kind of top level look, but I do think that there are going to be some continuing investments. And I think that some of those initial federal investments are for the initial infrastructure to kind of get this out of the Lifeline onto the 988. So I think we'll all be crossing our fingers
Yeah,
for
definitely.
25.
go ahead,
I
Alan.
just got a question. You know, we're talking about advertising 988, and it's 988's a new number. People have been 911 all these
Right.
years. So what's the relationship here between 911 and 988?
Yeah, so 911, the point person for 911 was part of our planning coalition for 988. So depending on where you want to go with this question, I'll go in one direction and let me know if I'm going in the wrong one. Someone reaches out to 988, is deemed an imminent risk of harm to themselves and needs medical attention. That's assessed by the person on the call. The person from the Lifeline Center is reaching out to 911 to make sure that there's a medical response to that individual. So there's that coordination. Does that?
No, that's true, because I said you're providing a service, but they're providing the service to that patient.
Service.
Yeah,
Yeah, a service to the service. There
Yeah.
you go.
Service to get them to the
Yeah.
service.
Okay.
yeah.
So this, if you can't answer this question, that's fine, but
Yeah.
and I don't know if you read 283. So 283 came to us with input from different advocates. And so they put in 283, a 988 Lifeline Fund, and a commission. So here, it looks like everything to do with 988 is managed within the DA system and DMH. So what roles do like your partners play, Center for Health and Learning, or whoever else might be involved?
Yeah, the role that AFSP role definitely plays is on advocacy, making sure that 988 is funded. The role that CHL would play would be making sure that individuals that are seeking further treatment or further training that are answering calls from the Lifeline Center have training that's appropriate for 988. So the individuals that are at Lifeline centers as well are trained by NKHS and NCSS. It would be more like additional supplemental training that CHL would be able to provide around zero suicide, UMAT, all of their
Okay.
suicide prevention.
So not directly related to 988.
Correct.
And so are you, as the agencies responsible for this, are you asking for a Lifeline Fund or a 988 commission?
No.
Yeah.
No, I mean, what we have done thus far is utilize the federal grants, and I think the planning grant was the place where we could help figure out what is this going to cost. Originally, they've given us, they being the national folks, a calculator, but in Vermont, it just hasn't borne out the same as in other states. So we've been using that to plan the funds. I think from our perspective, we've asked for the funding that keeps the Lifeline going. We have some concerns about the variability of not knowing what the budget might be through that type of process. So it's something we would be willing to talk about further on.
Okay. But you, as the agency, would be coming forth with continuing requests to fund the 988 line, as far as you know today.
We have every reason to believe by demand that the ask will be adjusted per year based on usage and need.
Great.
Yeah, it's a really dynamic number, as you saw with the previous months here in terms of the call volume and chat and text volume. What is important, though, to keep in mind too is that, or what's encouraging from my standpoint, is that more and more people that are calling means that more and more people know about what is available. And that's something that I'm in support of.
Yeah, definitely.
And that the quality in terms of the answer rate is still there despite that increased volume.
And is there any metrics, sorry, Leslie, is there any metrics or data analysis you can even do, for, in 2025, when we come back and are having the discussion about budget, that you could say, and I don't even know if this is possible, well, we've answered this many calls and this has been offset, like this cost, whether it be EDs or other DA visits, has been offset by the fact that we're able to answer these calls. Is there any type of analysis that's even able to be done?
Do you mind if I clarify your question?
No, go ahead.
So are you asking if we're able to analyze a decrease in calls to say first call at Howard Center to the 988 helpline?
That would be one example, yes.
Yeah. I haven't seen one. It would be really hard to capture that because I'm thinking about individuals that are in that crisis moment. They're likely going to gravitate towards a number that they're familiar with.
Which could still be.
It could be first call, right? There's repeat callers to these emergency services at all DAs. And so there could be a familiarity with the person that's reaching out to the crisis clinician that they feel more comfortable calling that individual. there could also be, there's some value to the anonymity of calling 988 as well.
Yeah, that's true. Daisy, you gonna say something or?
No, I was just contemplating data collection around this and
Yeah.
the longitudinal data that you have. And I'm guessing something like this is kind of what we have based on what we've been collecting since Lifeline days, and that it's kind of limited. And so, you know, as far as capturing any sort of outcomes, as with many things prevention oriented, you can't measure what doesn't happen in a way that's good, right? Like you can't measure people who were unsuccessful in completing suicide. And that's good, but it's also
Right.
not good.
Right.
If you're
Not good from a
focusing on that,
standard.
but it's fantastic. But is this kind of what we would expect to see from investments in 988? Is just simply success being the number of people that turn and call 988?
I would think so, yes.
That's
It's-
meeting that capacity.
It is meeting that capacity. And I think what's really important to remember is that, and fact check me on in terms of where we were when we were at 0% for answering in-state calls,
Right.
2017,
Yeah.
2018.
Not that long ago.
So not that long ago, we were answering no calls from Vermonters within the state of Vermont
Right.
to the suicide prevention lifeline. So to come, you know, to 83%,
Yeah,
that's
that's great.
with the new program as well.
Good.
Yeah.
You know, I'm just always looking to figure out how we can collect data. Bobby and then Copper.
Yeah.
Yeah, similar question.
And Leslie, sorry.
No
Which
worries.
is,
Yeah.
is there any way to break this down geographically from which, I guess you probably, it's too anonymous or?
It's a good question. I would likely have to pull in. So there's Vibrant Emotional Health is who SAMHSA contracts with to administer 988 from a countrywide standpoint. 988 gathers a lot more data. And so it would probably be a data collection request into them in terms of where the calls are coming in from, and like pinging the cell tower or IP address for chats and texts.
Yeah, because that sounds like a forensic thing, like if there was an investigation. But I just wouldn't want to know if there's a particular hotspot, you know, like in the state that we would be able to find out, because it also could be a diagnostic tool, like there's something going on in a community, you know. That's what I was wondering about. But I could imagine that would be very difficult to do, especially since people are calling anonymously and they might be using somebody else's phone. And there's a million other reasons why you'd never know for sure. I just curious.
You bring up a good point though, and I can certainly bring that to the Vibrant team and see if that's something if that's a request that they've been able to fulfill from other states.
Yeah.
That'd
So
be helpful. Or whatever other states are asking for data.
yeah,
Just zip code.
Yeah, that's
Yeah.
exactly. Zip code enough would be enough.
yeah.
Leslie,
Leslie, go.
Oh, no, go ahead.
thanks. I'm a person that calls. Can you just run quickly through what happens to me?
First, I would ask, are you calling on behalf of someone or are you calling because you're in
I'm
crisis?
calling for myself.
You're calling for yourself and you're in crisis. So you would fill out this, you go through this, this pre-call survey. So on the call, it would ask if you'd want to be connected with the main 988 lifeline, the veterans line, which there's a different veterans crisis line. And then there's actually a pilot that just went out nationally from Vibrant that's funded through Vibrant, that is focused exclusively on LGBTQ plus. And I do have another slide on a couple other pilots that they're working on. But once you fill out that survey, you would be connected with.
Once I fill out the
Well,
survey.
you're asking questions, right?
Yeah,
It's verbal. They're talking to a human.
yeah,
So you ask me the question, I answer it.
yeah.
Yeah, okay. So the survey's done. Now what happens?
Then you're talking to you and I are talking, I'm hearing what you're going through.
Yeah.
What you need at this time, how I can help. It's a supportive conversation that's really all about how can I be of service to you?
Okay, and now we hang up.
Mhm.
Does anything else happen after that?
It depends on the content of the call. There could be a follow-up a few days later. Does that help?
Could be a call.
Yeah.
What would make a call necessary?
What would make a follow-up necessary? Someone that could be describing a plan,
Yeah.
might not have the means.
How about if the person asks for a follow-up? Does that ever happen? Like, so
Yeah.
we've ended the conversation, wow, it'd be great, can you just check on me in a couple days?
Mhm.
Would that happen?
That I'm not certain of. I don't know if that's happening.
What's been part of the push now is to, and one of the things we are seeing, if we can track of how often a follow-up is offered and how often it's accepted. And so a lot of times, people might be surprised, people don't want to follow up. In fact, it's because then it's like saying, now I've called, I'm enrolled, and they're trying not to be in that space. But there are other times where they might want one. And so that is something that's being looked at now of how are we asking that question? Are we only asking it when right now it's more based on risk, but could we be offering that more often? So I would say the follow-up piece of 98 is still in like the development stage.
Does that help?
Yeah, it does. To
Okay.
me, if,
Yeah.
I would, if I'm taking that call, I've got that in my mind, this person is in crisis. So after I hang up, what's going on? I would probably say, hey, do you mind if I call you tomorrow?
I hope so, yeah.
And if they say no, I guess that's it. But if they said, well, wouldn't hurt. To me, you gotta, if somebody's in crisis like that, you gotta stay with them. That's why I went abruptly and said, now we hang up. What happens?
I'm wondering if it would be helpful, and it probably won't happen this week, but at some point before we're out of session, if we bring someone in who does the calls, do you think that would be possible?
Yeah.
Absolutely.
Okay.
There's Josh Burke and Tony Stevens, those are the two program managers, one at NKHS and one at NCSS.
Okay, that might be helpful just for us to really understand what the, Ellen?
No, that's it.
Okay. Leslie?
And that's an interesting question, is how many people who have contacted 988 go on to complete? Or, what do we don't know what happens to them. And I think that that's important. You had mentioned the Howard Center and how many people then go there. So there's a lot of touches, but is there correlation, or is it just cause what's the connection of the intervention?
Right.
How effective is it? And I'm not sure I see that yet, and we may not be there
Well,
yet.
I don't think we can, right? Because we're not asking for people to give their contact information, correct? Right, I mean,
No.
they can just call and be anonymous. So
Yeah.
So I think I think that's important, but I think it's also a weakness, I guess, because we don't know how effective, that this is, if we don't know what people end up, what action they do after. If they go get therapy, then that would be fantastic, if they go, whatever. Anyway, that's a worry of mine in the, what's the outcome? What
Right.
outcomes are we measuring?
Right,
Not
and that's,
clear.
right, and that's what I was getting to earlier with what data can we get
Yeah.
to prove that it's working, but it's really hard because we want it to be anonymous if the person wants it to be anonymous. We want to be able to provide, at least I believe, we want to be able to provide a service that people will use because it works for them, rather than, oh, well, we need to collect these 5 pieces of information from you so that we can do our data
No,
analysis.
but that's both sides of the continuum.
Right.
There's some middle ground, I hope,
Yeah.
that
so
says,
what?
that we hope.
Because you don't know.
Yeah, because you don't know. Was this intervention have any value for, at all, that we don't, I mean, yeah, the calls are answered and that's cool, but we don't.
It's a national standard, though. You cannot collect certain data. So, and that is how, that's the success of this, right? Is that it gives people safety and security and the anonymity.
Well, how do we know
If you
that?
start talking about,
Well, we could talk about this.
you
offline.
can go look up the model, right? And
No,
you
I
can go
get
look
that.
at the outcomes in other areas. But by offering people the privacy of a safe space with trained clinicians, people are using this. And
Is it preventing?
well, that's the thing with prevention models is you can't measure, that's what I was saying, is you can't measure how many people change their mind.
But we know we have
With any
958 people that called. I mean, I get that we can't contact them. I mean, if that's the national model, but I'm struggling with that.
Right.
Because we don't,
That's prevention.
well, not necessarily. We don't know what we prevented.
Well,
We
right.
may not have prevented anything. I mean, we don't know.
So let's have this discussion when we do our committee discussion
Yeah.
on Thursday. And let's keep.
That even wasn't my
forward.
question.
Okay, what's your question?
I was sort of struck by this commission thing that came up, and then I read about it in the bill.
What commission?
283 about having the commission shall award, having a commission.
A 988 commission? Yes.
And you said no. You were very clear that you didn't think we needed one.
Different, that was about the, taxing.
So I asked two questions. 988
Okay, sorry.
Lifeline Fund,
Uh-huh.
right? So that's a no.
You don't think we need that? And the commission, do you think we need that?
So there was a 988 commission
Yeah.
in as well.
In the bill? I mean, you may have not seen it lately, and I get it. But I'm curious to know what your thinking is, because if at some point you get to look at it, if you don't think that we need one, who does that? Well, I want to know who does that work. That someone thinks we need a commission, if there isn't one.
Right, so we're gonna hear from some more people
Okay.
on this.
Thank you.
All right, so let's get past the numbers.
Yeah, so I just wanted to highlight these 988 pilots that I mentioned earlier about that Vibrant is administering from the national side, so it's completely funded by them. So as of, a week and a half ago, the LGBTQ plus pilot line is now available 24/7. And by call and chat. And then they're working on developing further partnerships and programs as well.
And so are these pilots being answered by Vermonters as well, or is this at a national site?
That's a really good question, and I don't know. My inclination would be that it would be answered by people at the national. So there's state queues and then there's national queues. I'm gonna think, I will confirm this, but I do think that it's answered by the national queue.
Okay.
Because the individuals that are working on the LGBTQ plus line have specifically received training on working with the population that is in crisis.
Okay.
And to my knowledge, that's not something that we've done in the state of Vermont.
Tupper?
And are the people that are answering the line, are they LGBTQ plus people?
So the person at the Lifeline Center that's answering the phone, again, I would have to follow up on
You
that.
mentioned people get trained,
Mhm.
and I'm wondering if they are in fact.
Yeah, if they identify as LGBTQ plus, that I would have to confirm with Vibrant.
Okay, my next question was, I know there's a veterans thing.
Mhm.
And veterans answer that line. Why it was this singled out?
Why are these populations
Right.
singled out?
They're more, go ahead, you answer that.
No, it sounds like you had a follow-up to that. I want
I
to.
don't listen. They answer a certain way.
So why these populations have been singled out is, I can't speak to exactly why Vibrant singled them out, as I don't work for them, but I can say that these individuals have had, are at higher risk of suicide.
That's veterans are.
Yep.
I'm talking about both.
Yeah, yeah.
Okay.
Yeah, so we know that Native peoples and tribal communities are at high risk of suicide.
Sure.
Okay, great.
That's all that I have on 988.
Okay, so any other questions before we move to zero suicide? I don't know if did Nick have anything, or was this gonna be mostly you?
I think it was mostly me, but I don't know if there was anything Nick wanted to chime in on.
No, I'm all set. Thanks.
Okay, so zero suicide.
I'm just gonna take a
Yeah,
quick swig of water.
And I think Nick does Nick have stuff on zero suicide too? I think I saw in his presentation, so we'll.
He does,
Back
yeah.
and forth, okay, so whoever wants to go first.
I can start and we'll see where that ends us.
Okay,
So I'll start with the zero suicide funding breakdown. This is the grant to CHL to implement zero suicide throughout the state. So $495. And this is what the zero suicide implementation is on the left-hand side of this slide. We're also looking at the this suicide prevention symposium, which happens annually, that Center for Health and Learning plans, manages, and delivers every year.
so what happens after June 30th of 2023?
Then,
Yeah.
yeah.
So that's our base budget, and so we administer the grant every year, we just
Okay.
look at the activities.
Okay, so this is the same amount that's in the 24 budget, okay.
And go for it.
No, I think I'm good on the numbers. Anyone have questions on the numbers? Can come back to it once we dig into a little bit of what zero suicide does.
Very well. Yeah, so wanted to outline some zero suicide outcomes that we've seen statewide. The first point here is listing a few of the trainings that Center for Health and Learning has administered, their evidence-based best practices. You got CAMS, CSSRS, and CALM. They've also identified some new trainings that they wanted to implement as well regarding follow-up and care in context, EHR, so electronic health record training, making sure that we're able to pull data that's needed for zero suicide outcomes. Conversations on suicide is another training, peer model. Then support for youth and schools through UMatter Gatekeeper training. Last year, there were 108 participants. We have monthly coalition meetings with state partners and program leaders to coordinate efforts. That's ongoing. Like I said, it's been going for years. In the fall, last fall, there was a Zero Suicide Practice Institute, so bringing all the designated agencies together to coordinate efforts. There's some designated agencies that are a little bit further along in implementing zero suicide, the framework within the agency. So wanting to make sure that there's a forum for them to network and share those ideas. There are 38 attendees there. At the annual Suicide Prevention Symposium, there are 231 attendees. So all good stuff. And then we have zero suicide steering committees. 6 of the 7 are active right now. So, which is great. We need that leadership buy-in to continue to implement zero suicide throughout the different departments at each DA.
So quick question. So we're paying CHL to administer all of this training. Do we give anything to the DAs for doing the zero suicide work other than the way they get funded?
Yeah, so there is another, so part of the CHL grant, there's the mini grant project, which speaks more to, I think I actually have my next, not the next slide, but I do have another slide on this mini grant project that aligns a designated agency with a PCP office, although there's a different acronym for it.
Okay, that's fine. We can wait till we get to the slide.
Yeah. Question?
Some of those trainings, they need to keep their licensure up and they get CEUs
Right, yeah, no, no.
and stuff like that. So.
Yeah, so just wanted to outline the training numbers for various trainings that have been held. This is for Q2 of this current grant year. So almost 700 participants in a quarter in trainings is really great, especially having the number of CAMs. CAMS is the Collaborative Assessment and Management of Suicidality, which is a best practice. So making sure that there's clinicians that are trained in how to work with someone that is experiencing suicidality.
So people are offered the trainings. It's not like anyone is mandated to train for zero suicide. Okay, thanks. Okay.
So this is the mini grant project that I was just alluding to. So the idea of this project is to pair a designated agency with a patient-centered medical home. That's where the PCP is, but so where someone gets their primary care. This is in order to develop suicide-safe pathways. So making sure that individuals are both screened, assessed, and their suicidality is managed in both settings, and safety plans are put in place if needed. And some of the measures that we're using are what screener was used. So seeing if they're using the CSSRS, which is the Columbia Suicide Severity Rating Scale. Was a referral made? Was there a warm handoff between the two? Did coordination with the patient-centered medical home, did that occur? Was CALM, which is counseling on access to lethal means, which is another evidence-based practice, is that documented? And has CAMS training begun for clinical staff? I think, yeah.
Good.
These people here that we're talking about appear to, you know their name.
Yes,
So these people, okay, get back to my.
I might not, but
They-
Get back to the original thing. I'm the person that called. You didn't know who I was or anything, but how do you find out who I am? If we never call them back or we don't follow up on them. So how do they get to this point?
how did
How do they
they?
get to this point?
These are two separate things, 988 versus this, right?
Yeah, but okay.
But how are they coordinated? Is that what your question is?
Somebody
Yeah.
I call. I'm just trying to figure out what good is 988? If we don't know anything about what happens afterwards. Whether they end up in this program that's helping them. I don't see a continuum of the system that we have in place. I don't see how it's connected yet. So maybe I'm not supposed to. I don't know.
Maybe I'll try and connect some of those dots.
Okay,
So someone calls in, they're in crisis to 988.
yeah,
Crisis is handled. The person that's at the Lifeline Center at NKHS or NCSS has handled that crisis. They're now able to ask if the individual wants resources.
yeah.
and if they want the phone number of their local designated agency. If that individual says yes, then that number is provided, any resource could be provided at that point.
Yep.
But every person that works at the Lifeline Center has access to those resources. There's a whole database that we have. So ideally, that person that called into the 988 crisis line is able to then follow up with that designated agency, or at least knows that it's there, that they can access it when they feel that they're able to access it. I do understand your concern.
You never know.
about that outcome.
So you never know whether or not it was me when I walked through the doors at the designated agency.
Correct.
No one ever knows if I called on that line. Okay.
And there's an importance in that the designated agency doesn't know if I called in on the 988 crisis line because of the importance of anonymity within when someone is in crisis, and being able to reach out to someone that doesn't know them, will not judge them, offers that space to express what is going on for them.
Okay.
Alyssa? And then Art?
I'm trying to figure out how this is working. So does the DA have somebody embedded in the practice, or is it more that, if somebody comes into their primary care, concern about suicidality or something like that, then they just call the DA and then the DA sends somebody and that's where the handoff is taken? Is that what I'm looking at here?
I hope I'm going to answer your question because it's an important one. I want to make sure that it's understood so someone goes to Cold Hollow Family Practice, they're in this mini grant project. The individual that goes into Cold Hollow Family Practice, the nurse or whoever they're seeing, screens them, assesses them, and then if that individual sees that they might need a safety plan, either starts that safety planning process at that point, and then also connects them with the DA, the designated agency.
Okay.
So then that information that was shared with Cold Hollow Family Practice is now being shared with NCSS.
Okay.
To make sure that they know about this individual, that the screening and assessment has already taken place, and that safety planning has begun. And I think this is where the warm handoff is critical, is that you don't say, if I'm at Cold Hollow Family Practice and I'm seeing Tom, and we've started the safety planning process, that I don't say to Tom, hey, go see Jennifer at NCSS. I say, we'll call Jennifer together and we're going to have a conversation about what is going on for you, where we're at screening assessment wise, and how can we help you through this safety planning process. And now Jennifer is able to take it from there. And then there's this exchange of communication both ways.
I guess I'm just trying to figure out how it's any different than, I mean, I know if we've identified, in the practice I work in, if we've identified somebody at risk, we call crisis at Howard, and Howard actually sends somebody out there, and they always have. How is this different?
This is capturing people that aren't in crisis.
So it's just using a screener.
Yeah.
But that's what you're saying your practice does. Is that what you?
I think most
There's
practices
something that you wanted to
screen
add.
anyways and always have screened, but
Yeah, I think what we found is across the state, A, that's not everywhere, what you're describing. And B, it's not always looking for a crisis response. And so a lot of times people take the screener and they fall below the imminent risk level, but they have suicidal ideation or depression or thoughts. And so this was a way to your question about giving money to the DAs, paying for their time to go and meet with each of these practices in their community and ask the question, what do you do? Some of them screen, not all of them do. Some of them screen, but only know to call an emergency service if it's on fire. So it was all over the map. So this was saying, write it down. Here's what you're gonna do if it's a X on the scale, a Y on the scale, or a Z. And also, by the way, it's not just enough to say, hey, you should go see a therapist. Here's the place to call, and we're gonna ask you to follow up and make sure they actually showed up. So it's that whole thing, is writing a protocol down and having everybody agree to it.
Okay. And I'm also trying to figure out how it's not also slightly duplicating the community health teams through the Blueprint.
So the Blueprint is involved, and we actually utilize and leverage their program managers. So the only money going towards this was the time for the two entities to come together and write the protocols. But the Blueprint program managers are the ones who facilitate all the meetings, and they're doing the quality review of whether or not it's happening, if it's happening well.
And so these people, we do know, and so there could be some long-term tracking of the results. Okay. And is that set to happen long-term tracking? Okay.
And I just, I'm trying to
I know.
Excuse me.
But I did want to say for 988, and this will come about if you talk to the centers, there's a lot of data collected. It's just not tracking the person. And again, we can go back to whether that's meeting our needs or the person's needs. I think the person needs that space. But there is a big movement now to start tracking follow-up and whether or not it's done. And you can have more like indicators. So for example, you may not know that X person then went here, but you could know out of all the people who called, this many people of them got a follow-up. And so those are the types of things. And you'll learn there's even more than that. Like, was the call appropriate? Back to the question of, there have been a few callers who are calling for appropriate reasons. And then was the call de-escalated? Was there an imminent risk that required de-escalation? De-escalation. And then the third piece I'll just say is we tried and hoped to work with 911 to say, can we tell if 988 is now decreasing suicidal callers to 911?
That's good, yeah, cool.
Be surprised how tricky it is to get data out of 911 because it's locally dispatched. So we're struggling with that, but it's a thread that I think we're trying to pull at. And I think where we're going with it now is tracking police response to suicidality, because at least for the local police, that local response is tracked. So ideally through this program, you're having less police dispatches to people's homes, people who are suicidal, and more phone conversations and connection to counselors. That would be something.
That's interesting.
Thank you.
Yeah.
Art, sorry.
Yeah, and what you just said, Allison, kind of leads me to my question of just thinking about all this. The 988 calls take, do we have a record of the call? I'm just thinking of, this is sensitive information, so we don't want to get names, but if we had, I didn't know how much of this we saved so that we can track the thing later. Do we do any of that?
The National Lifeline is the one ultimately responsible, and they're the ones who certify these centers, and they do quality checks. So and it's important for people to know this, we as the state of Vermont aren't able to go in and listen to anybody's, things like that. But the National Lifeline does have quality checks, and they're there to ensure that things are appropriate, high quality, and that the risk assessment is happening. But we aren't tracking it in that way.
You're not tracking, so you don't give somebody if I called in, as in Topper's example, I call in with an issue, you don't give me a number or something, the client XYZ called in, he had this problem, he said this on this day and this time, nothing like that.
They categorize the need. So it'll be like a person will call, you get what the people are willing to give. So a lot of people are willing to give.
Right.
Name, where they're calling from, age, gender, orientation. That information, if offered, is collected. So there's actually a treasure trove of data. It's just optional. And they do collect the reason for the call. And it is, the majority are non-admittedly suicidal. Some are financial stress, some are legal stress, some are, so there are categories, and it would be great, that's where, it'd be great to pull in the 90-day folks that could tell you how they ask that question, how they're going to answer.
It just would seem we'd want background information if they're calling, but there are legal ramifications, I'm sure.
All right.
You got their number.
And that's how an
True.
emergency situation is managed.
Yeah, true. If that's kept, then how do you find it?
Somebody's really at risk, then
Yeah. You got
I don't know, I'm not.
So at some point, I'll reach out to see if we can get the folks who are answering the phones to come in. All right, let's keep going because we're.
Just wanted to offer the client level measurements that we're measuring right now. So screening, the measurement exactly is number of clients who received a suicide screening during the reporting period. Assessment, so number of clients who screened positive for suicide risk and had a comprehensive risk assessment during the same day. And then the safety plan development. So number of clients that have a safety plan developed the same day as screening positive. Ideally, these are happening in quick succession within 24 hours of screening.
Is this zero suicide in general, or this goes back to the mini grants?
This is zero suicide in general.
Okay.
I have a question on that.
Oh, I'm sorry, go ahead.
Okay, so you do know the number of clients who screen positive for suicide risk at the DA level?
Sorry, I just wanted to go back to your question. This is just for the mini grant.
Is it just for the mini
Yeah.
grant? Okay.
Oh, okay, all right.
Does that help?
Well, I think this is important because if we're getting, I guess my pea-sized brain goes back to the number of calls you get in 988 and how many of them actually have something to do with suicide. And maybe.
I think you're gonna have to get onto my way of thinking now. They're two separate things.
Right.
Must be a Massachusetts thing. I don't know.
There are two separate things, and I also want to be clear, 988 is not just for suicide prevention.
Correct. Well,
988 is also if you're in crisis. I want to be clear because we want people to call 988 for all of those reasons.
right, okay, yeah.
Can I ask about that?
Sure.
Because you mentioned something about legal problems, financial problems, so they have a whole array of resources for all those things? They refer people to lawyers, or how does that work?
Let's write down all of our questions we have for the folks who do 988.
Okay.
We'll have them in.
Thank you.
Yeah.
Good question, though.
You're very good, you know that, right? You're very good.
I get convinced.
So here on this chart or this graph, we're looking at the screening, assessment, and safety planning in 4 agencies. So this is just for the mini grant. So this is the data that we were able to compile and look at screening, assessment, and safety planning, making sure that those are happening at exactly the appropriate time.
Great.
And then looking ahead to the findings from the Zero Suicide 2023 Planning and Reporting Survey. So this is the level of implementation of zero suicide in each department at each DA. So as you can see, some departments are further along in terms of zero suicide implementation. So you'll notice that emergency and crisis services, and then CRT, community rehab and treatment services. So those are the highest level of risk of individuals of suicide typically that are serviced by a DA. And so that's where our zero suicide initiative started in terms of engaging those teams first. But what's really encouraging is that, that you have, zero suicide, the framework being implemented at least at every, DA across departments, which is it's a tall task because you need leadership at each department to push this initiative forward.
Right. Okay.
Yeah.
Oh, hold on.
Yeah.
Those last, the safety planning. You assessed 100% of the people, but only 78 and 85% got the planning. Is that the way I'm reading it?
Can you say that again?
100% of the people were assessed that came through the screening. Okay, so you have 100% of those people. Now, why, just out of curiosity, why didn't that 100%? Why didn't all those people get safety planning?
It's possible that the safety planning was done outside of that 24-hour period that we're measuring safety planning happening,
Okay,
if that makes sense. So 85% happened within that 24-hour period. That doesn't necessarily mean that the other 15 didn't.
all right.
Good question. I like that.
Well, the reason I ask it is because those people are in trouble.
Yeah. And not only are those people in trouble, but we know that they're in trouble. And then how are we
Yeah.
appropriately addressing
Yeah,
that?
exactly. Okay.
Any questions on this slide? Okay. So through a survey, we identified some agency priorities for future zero suicide work. So training and expanding protocols and building pathways to care, and engaging community partners at the top of the priority list there. So making sure that, clinicians throughout the various departments are trained in these evidence-based practices, CALM, CAMS, CSSRS, making sure that there's clear and concise protocols within the agency that people are aware of, know how to follow them, and carry that out. And then they see that the building pathways to care with PCPs. So going back to the mini grant project to the patient-centered medical homes, making sure that there's the suicide safe transitions and care, and engaging community partners, right? Leslie, earlier you talked about an individual that has died by suicide in your community and the ripple effects of that. So how are we engaging the local why that the individual served on the board and, things like that.
So the percentage is the percentage that you hope to meet or the percentage of where you are today on each of these?
The percentage of DAs that identified this as a priority,
Okay.
for zero suicide.
Okay.
And then that's actually it for zero suicide specifically.
Okay. And I think Nick had some stuff though. Nick, are you there?
I am here, yes.
Do you have items on zero suicide?
I do. I'd be happy to speak to them. How much time would you like me to take?
Well, I do want to try and get to community education. So which I'm going to let you determine that.
Okay, I can be
So
really.
we have till 4:30.
Yeah, so I'll actually just be really brief and say that, in addition to the work that's happening with the Department of Health, with the Department of Mental Health and zero suicide, through the CDC grant that the Department of Health has, we also have funding to support zero suicide. And so we're prioritizing that funding to look at expanding zero suicide in other healthcare settings. And Chris already talked about our partnership to support the mini grant project with primary care practices. That's actually funded jointly by the Department of Mental Health the Department of Health. And then I was just going to briefly mention that we also have been able to start a zero suicide project with emergency departments. And we've been really happy to have all 14 of our hospitals and their emergency departments engage in a quality improvement project using the zero suicide framework. It started last year. It was led by the Vermont Program in Quality in Healthcare. It follows all of the same tenets and principles of zero suicide, but looking at how you would apply that to an emergency department. And so as people are coming to the emergency department, regardless of whether they're there for a mental health issue, are they getting screened? If they get screened for sort of positive potential suicide risk, is there a full risk assessment? Are you doing things like looking at counseling on access to lethal means? Are you looking at like if this person is at risk when they return out of the emergency department? Do they have firearms at home or other items? If so, how do we have a conversation about maybe having those placed somewhere else temporarily if they're at risk? Also looking at making sure that people are set up to receive appropriate care once they follow their stay at the emergency department, as well as are they being followed up with in case they don't connect with their care. So I'll just sort of leave it at that. But if you have, if folks are more interested in information about that first year of what's happened in the emergency departments, we have a nice 2-page impact report that the Vermont Program for Quality in Healthcare develops. And that project is going to be continuing on for the next couple of years. So I'll leave it at that.
Okay, thank you.
Yeah.
All right, community education. Is that you or Chris?
Both of us, I think.
Okay, so Chris just left the room. Do you want to kick us off? Is that possible?
Absolutely.
Okay.
Oh, and by the way, I forgot that today is National Pie Day, in case anyone doesn't know. So if you haven't already, make sure to.
I care.
Pie day.
Pie day.
Yeah, I heard about that.
Yeah.
PI or PIE?
PIE.
314.
High before.
0.14.
Okay, we're gonna stay focused.
Right. I mean,
All right.
the committee with some food.
Kick us off, Nick.
Yeah, so one of the major components of our CDC CSP grant is community education. And you may have remembered I talked about this previously, but we know that the majority of people who die by suicide in Vermont are not actively connected with mental health treatment when they die. And so because of that, we want to make sure that we have a broad set of community partners who are not mental health clinicians, but who may be in a position to recognize when someone is struggling or at risk, and then knowing what to do if they recognize that that person is struggling. And so through a broad set of community education, we are engaging with many different organizations. I'm trying to teach them how to be more comfortable around how to recognize when someone may be struggling, and then how to support them. And so through this grant, we have been working with the Center for Health and Learning to expand what we call suicide awareness and support training for community partners. And that includes, we've basically been offering different kinds of training under this broad category to anyone who wants to partake in the training. But we've also been focusing specifically on some programs that we know are experiencing either death or morbidity associated with suicidality at a greater rate than the general public. And so we've been purposely reaching out to several different types of programs, for instance, programs that serve LGBTQ individuals, programs that serve rural Vermonters, as well as men, because as you may remember, men actually, the majority of people who die by suicide every year are male. As well as people living with disabilities. And so over this past year, we've been reaching out and been able to provide a lot of community education and training for programs that both serve those groups as well as some other groups. And this type of education, the good news is that there's a lot of it that already exists, and there's a lot of different partners who already offer it. And so through this grant, we've been partnering with a lot of different organizations just to expand and make what they have available more available across the board. And so, for instance, you may have heard of some of these models. There's something called You Matter, which is run by the Center for Health and Learning. Mental Health First Aid is another model. Question, Persuade, Refer, or QPR as well as Talk Saves Lives and Conversations About Suicide. And so our primary partners that we've been working with, there are four. The Center for Health and Learning has been our lead organization. They're coordinating the promotion and helping people connect with training, and they're also providing the training in some cases, or helping people access other trainings. We're also working with our designated agencies. Several of them offer both mental health first aid, as well as question, persuade, refer, or QPR. And then some of them also offer something called Assist, which actually is a 2-day training, which is the training that people on the 988 crisis line use to intervene when someone may be at risk in the moment. We also work with the American Foundation for Suicide Prevention. They have a version of this training called Talk Saves Lives. And then Pathways Vermont also has their own version of the training called Conversations About Suicide. And so we've really been doing this for about 8 months. That's when things really kicked off, but we've had some really nice outcomes in terms of what we've been able to accomplish doing suicide awareness training throughout the state. And so just last year, we've been able to partner with over 80 different private and public organizations. That's resulted in over 200 community members and professionals trained in suicide awareness. And we've developed some nice connections with various programs that serve some of our focus populations. And so, for example, we're working with Farm First to make this training available throughout the agricultural community. We've been working with first responders like law enforcement and emergency medical services to make sure that they have this training. We're able to train a broad set of pharmacists around the state on suicide awareness, as well as programs like librarians, as well as Capstone Community Action. And the great other outcome that we've seen is following the training, we ask people, do you agree with the following statements? I am confident in my ability to recognize the signs and symptoms of people who may be at risk for suicide. And then, are you confident that you know what to do if someone wants to take their life? And 90% of people who take the training agree that they feel confident in their ability to both recognize when someone's struggling, and then they know what to do. And so that means that they're leaving that training with the ability to recognize someone in the community and then intervene. And then the other thing that we're excited about in terms of our outcomes is we've been, collecting the contacts of everyone who's taking the training. And then 6 months following the training, we're going to be reaching out to every single person and asking them, have they been able to use the training to actually ask someone if they're considering suicide and intervening. And so we're hoping to really see, at least measure the degree to which community programs are using this training to intervene with people who they may be working with. And then for this current year, we have a very ambitious plan. We already have 19 additional trainings that are planned. And then we're also looking to expand it to other programs and industries and groups where we know people are at risk. And so, for instance, we're going to be working to make this available through employees of construction companies, as well as disability and aging service programs. I'm doing more work with LGBT programs. We're really looking forward to partnering with the media. Interestingly enough, we've gotten some inquiries among the media, not only to know about how they report about suicide, but also how do they themselves know to when to recognize and support someone who may be struggling. And then we also really want to reach out to the gun owning community to also promote and expand suicide awareness among those populations. And then through sustainability, or as a way for sustainability, we're hoping to work with a number of these programs and start to train their staff on how to provide this community education. So that should help the sustainability as time goes along. And just in terms of community education, I think, Chris touched on it at the beginning of the session, but the other major arm of what we're doing is our Facing Suicide VT campaign. And that page is, or that site, it's not only a website, but it's also a public health campaign. And so in addition to the website that we have available, we've been using paid promotion of the website and the content and the stories from that website to encourage people just to be talking about and thinking about suicide as an issue that we all should be addressing, and using that attention to drive people towards places like Facing Suicide VT. So that was a very quick summary of what our grant is doing around community education.
And thank you for that. And just for the committee, we're also going to talk about education in schools and what's happening there. So this will have a much broader conversation. Alyssa?
I just was wondering, because I happened to be driving a fair amount this weekend, and I heard an ad on the radio about safe storage. Is that part of this? I mean, it was like the list of contributing agencies was half the ad. So I'm just wondering if this was a part of it.
Yeah, so that was something that was not led by the CSP grant, but we got invited to participate, and it actually is in line with one of our other strategies is to promote safe storage in households, because we know when guns are stored safely, unlocked, and ammunition stored separately and having the gun locked, it reduces the risk not only of suicide death, but also of accidental injury. And so we participated in that initiative. It's called Gun Safe VT. It actually was initiated by the U.S. Attorney's Office in the Vermont districts. If you have time, I would encourage you to check out the website. But yeah, we worked with them, and as you said, a number of different partners to develop some specific PSAs that encourage people to think about both, storing their firearms safely, and then also knowing what to do if someone in your household is going through a crisis, and understanding that, hey, if that happens, it may be a good time for you to actually temporarily store your firearm off-site. As part of the website, there's actually a map of different locations around the state where you can store your firearms temporarily off-site. But anyway, yeah, so we were not the instigators of the project, but we did work with them, so.
I appreciated how suicide specific it was, actually.
What's the website, Nick?
It's called gunsafevt.org.
Thanks. So I think we're almost done because it's been a long day. And I want to say how thankful I am for all the work that's been happening in our state. And I'm going to ask a question, and I want to preface it with the fact that I am encouraged by everything that's happening, encouraged by Chris being here. When I recognize all the work that Allison has done on top of, all her other work. But I have to ask this question. Suicides each year are higher in Vermont. Our deaths are higher. So when do we start seeing the impact, or or what are the gaps in order to make that? Is it time because we're really just ramping up with a lot of this? Are there gaps we need to support you with?
Well, that's a great question, and I'll also let give space for Chris and Allison to comment. So I do think having done suicide prevention work previously when I was at DMH. Sorry, that's my school calling to let me know that all after-school activities are canceled. If you have kids at school. It goes to every phone in my house.
Yes.
I think it is going to take a fair amount of time to see a significant change. But when you look at national standards in terms of all the things that states should be doing, the good news is that Vermont is either starting to engage in those things or planning to engage with them. But it's a multi-year process, and so. I think as we make progress and try to make progress in all these different areas, we're going to discover some of this is much harder to accomplish. And in some cases, you make progress after a year and then you backslide. So I think, I would love to see next year that it actually has, some of these changes are starting to have an effect. I think the hardest thing that we need to do and is going to take the most time is changing the stigma associated with suicide and changing people's ideals that it's not okay to talk about suicide, or that they need to suffer in silence, or that that they shouldn't reach out and ask for help, or it's a sign of weakness. And so I think because we have a lot of people who are not asking for help or not getting help, and I think that when you're looking at humans and behavior change, that's one of the hardest things to do. But we are starting to work on that. But I think that's probably in addition to all the work that we can do to improve our treatment system, continuing to invest more in changing the stigma and the beliefs around suicide is going to be incredibly important, and should allow us, once we have these solid treatment systems in place. I think we're seeing it with 988. Now that people know that it's there, more people are going to that line, which means that more people are saying like, oh, okay, now I know what to do if I'm struggling. But I think that's going to be a big piece of it. And I look forward to continuing to work with this committee on suicide. I think it's wonderful to have this much attention by the legislature on suicide. That wasn't always the case, but it's going to be a long journey. Absolutely.
Great. Thank you, Nick. I don't know if Allison or Chris want to add anything. You don't have to.
I would just say one of the indicators when I came to DMH and Zero Suicide had been implemented for a few years and we were trying to determine if it was making any difference. I was scrolling through these scorecards we had, and one of them was the number of people who died by suicide who were enrolled with a designated agency. And since pre-Zero Suicide implementation to post, it had gone down significantly. And that's where we put our first resource, was we started zoning in on, okay, if you're a clinician at these spaces, we're gonna arm you to know what to do. So that gave us an inclination that at least you get through those doors, there's real help. I think what's been so helpful about the CDC grant and Nick and the health department's work is there's so many people not going through those doors. I'm hopeful about some of the programs like the men's sheds, like man therapy, like anything that's teaching a community how to do a response. I would say the spaces maybe we haven't dove into as much as we could are employers. There's a unique opportunity there because it's one way to blanket everybody. You're all the same. You're all, it could happen to any single one of you. And so we're going to arm you all with what to do.
Yeah.
And then it's the hope piece. I think with the pandemic and isolation and the lack of things to look forward to, there was a slide back, particularly for younger people, but also for everyone. And so anything we can do to start infusing things that provide hope for youth, that's a lot of like music programs, drama, things that they can look forward to, like getting them involved in things like that, get something on their calendar. Like, I'm gonna hang in there for that.
Right.
Adults need that too.
Yeah.
But things like that.
Yeah. Okay. Thank you. And again, I asked the question because I think it needed to be asked, but I am very appreciative of all the work that's being done by everyone within all the organizations that are working on suicide prevention. So thank you very much. I think we're all back together again tomorrow. Actually, just Chris and Allison get to be here with us tomorrow afternoon or tomorrow morning with suicide prevention in schools. Nick, thank you again, and we'll reach out if we have any questions. But keep reach out to us too if there's things that we can help with. Definitely.